Hello, everyone, and good evening. My name is Natalie Richardson. I'm the Managing Director of Save Your Skin Foundation. I welcome you to today's webinar presentation titled Management of Melanoma Treatment in the COVID-19 Setting. To help us learn more about the challenges faced by a few centers in the Greater Toronto Area due to COVID-19, we are honored to have with us this evening 3 treating specialists on the front lines. Thank you, Surgical Oncologist Dr. Nicole IO Clinical Nurse Specialist Massey Nematollahi, and Medical Oncologist Dr. Marcus Butler for joining us. To facilitate the presentation, we have Kathy Barnard, metastatic melanoma survivor and patient advocate and the founder of Save Your Skin Foundation. I'll just run through everyone's short bios. Dr. Lokong is an associate scientist in the evaluative clinical sciences at ODAT Cancer Research Program, Sunnybrook Research Institute. She's a staff physician, Division of Surgical Oncology at Sunnybrook Health Sciences Center, and she is an assistant professor in the Department of Surgery at University of Toronto. Massey Nematollahi, RN, is an immuno-oncology nurse specialist who provides care in the leading-edge immunotherapy program at William Osler Health System in Brampton. Osler is one of Canada's largest community hospitals, serving the diverse and growing communities of Etobicoke, Brampton, and surrounding regions of the Central West Local Health Integration Network in Ontario. As a regional referral centre, Osler provides programs and services to over 1.3 million residents across the network. Dr. Marcus Butler, Medical Oncology Disease Site Lead for Melanoma and Skin Cancers at Princess Margaret Cancer Centre, and he is the Assistant Professor of Medicine at the University of Toronto. He's the Clinical Director for the Immune Monitoring Team at the Princess Margaret Cancer Centre, where he focuses on the immunologic impact of anti-cancer immunotherapies. Thank you, a deep felt thank you to each of you and your teams for your work in these areas and your unfaltering care during this challenging pandemic. We'll get started on the presentations in just a moment, but first a few logistics. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. There will be a question and answer portion at the end of the presentations. You'll see at the right-hand side of your screen an option to type in a question under the word chat. Please feel free to ask your questions throughout the presentation, and we will do our best to answer them in the last segment. If there are questions that do not get an immediate answer, we will contact you with a reply and any discussion you wish to have after the webinar via email. This session will be recorded and will be available for viewing on the Save Your Skin Foundation website and YouTube channel. Thank you again for joining us, and we will now begin the presentations. I hand this over to you, Kathy.
Thanks, Nat, and thanks everybody for joining us. Over the past few months, the COVID-19 pandemic has brought many challenges to our lives. As a population, we have found ourselves challenged by unprecedented considerations in everything we do. How we interact with others, how we work, how we perceive healthcare, and how we receive that healthcare. For cancer patients in particular, this pandemic has brought varied questions and changes to many cancer centers. Treating physicians have been put to the test in an already busy system to take care of the needs of patients in the oncology setting in resourceful ways, often coming up with solutions as conditions develop. For that, we can't thank them enough. And we're thrilled to have all 3 of you with us today. So I am honored to introduce one of those physicians to get us started, Dr. Nicole Lokong, Surgical Oncologist and Associate Scientist at Sunnybrook. Dr. Lokong, over to you.
Thanks very much. I'm just going to switch my screen over.
Perfect. Wonderful.
All right.
Thank you so much. Thanks.
So it's a real pleasure to be with everyone tonight. And as a surgical oncologist, it was my job to give a bit of context to some of the challenges that we faced trying to keep melanoma patients safe over the past couple of months, and a little bit about some of the directives that we were given as surgeons in terms of how do we manage people across North America in a consistent and largely safe manner. So I wanted to introduce some of the guidelines that we were governed by. And the first couple of slides are really from the Society of Surgical Oncology. And this is kind of our overarching society, and it governs people in North America primarily, and there's obviously an Asian and European cohort as well. But they put out a set of statements on March the 30th of 2020, basically to help guide us how to continue to evolve during the pandemic. So the overarching statement that they said was that the SSO supports the need for treatment decisions to be made on a case-by-case basis. And the surgeon's knowledge and, oh goodness, sorry about that. Surgeon's knowledge and understanding of the biology of each cancer, alternative treatment options, and institutional policy at the time of the patient will be scheduled for surgery really all need to be taken into consideration. So really, the overall statement is that the surgeon hopefully knows best, both in terms of their institution and their patient's cancer biology. And so when we started in lockdown at the end of March of 2020, these are some of the things that I think every hospital was trying to consider and to make policies on an individual basis how to move forward. Things to think about: potential shortages of personal protective equipment or PPE as time went by, potential shortages of hospital personnel due to sickness, due to quarantine, and due to other competing home priorities like having kids home from school, potential coming shortages of hospital beds with intensive care unit beds, and also the desire to keep as many patients safe as possible to maximize social distance among patients and colleagues while keeping the cancer safe and at bay as best we could. So every hospital dealt with these in different ways, but these were definitely some of the top priorities at the end of March. The SSO put out several specific guidelines with respect to melanoma, and I'm a part of the melanoma disease site group within the SSO. And so together, as a group of physicians across North America, we put together a few basic statements to help surgeons to be safe. The first one was really to delay wide local excision of in situ or very early melanoma for at least 3 months. And as resources become scarce, all of these lesions with negative margins, keeps taking out, all lesions with negative margins on initial biopsy. So as many of you might know, wide local excision is really the cornerstone of much of surgical management. Efforts should be made to perform procedures in an outpatient setting and limit the use of operating room resources. And if significant delay is expected, then a precise location of the residual melanoma should be marked. So there were a lot of creative ways that physicians were taking to mark the lesion of where a melanoma used to be, and these included, tattoo marks, photography, getting caregivers or patient family members to put markers near lesions. So all sorts of things that were being used across the country to creatively make sure that we could find the melanoma spot for excision later on. The next point was about using the thickness of the melanoma to try to triage who we should treat first. So surgical management of T3 or T4 melanomas, so those that were greater than 2 millimeters thickness, took priority over those that were T1 or T2. And this was a matter of severity, so made sense, with the exception of any melanoma that was partially or incompletely excised. And the goal here was really to say, if you have an obvious melanoma that you can see, one should take it out with margins that were grossly clear. So i.e. any pigmented lesion could be taken out, and that thicker melanomas took priority over less thick melanomas. So seemed to make sense. Sentinel lymph node biopsy is also a cornerstone of surgical melanoma management. And we had to triage who got priority for this as well. And so in general, we tried to preserve this for people with thicker, more high-risk lesions, greater than 1 millimeter. And if things were to get worse, then the thicker your melanoma, probably the more priority you became for lymph node staging. There was also resources, consideration for resources, in that if we really had no access to the operating room at all, sentinel lymph node biopsy could be set aside for 3 months. Management of stage 3 disease, so this is lymph node positive disease, often is managed with surgery first. But in the setting of the pandemic, often this was very difficult to access. So we put aside management strategies to try to manage these node positive patients with neoadjuvant systemic therapy first. And if resources permit, then we could then consider surgical management. And this is really in line with upcoming evidence showing that neoadjuvant treatment, meaning systemic treatment or immunotherapy treatment ahead of surgery, is actually a very good therapeutic strategy and is becoming more mainstream anyway. So this was preempting that a little bit. Metastatic resections, meaning stage 3 or stage 4 disease, really should be placed on hold unless they were critically symptomatic. And also radiation therapy could be considered as well for single site disease. So these were some of the overarching principles from the SSO. In concert with that, here in Ontario, Cancer Care Ontario put out some guidelines. This is also from Ontario Health, which is the overarching organization that now manages Cancer Care Ontario. But we manage surgical patients with priorities, as you see here, priority A, B, and C. And basically, these are in concert with some of our wait time priority categories. So basically, priority A became people in whom a delay in surgery would result in an immediate threat to life or limb. And so very few melanomas really fell into the priority A surgical category. But you see the rapidly growing lesions would, and that was kind of the only category. Priority B is the majority of surgical melanoma cases, and they too, similar to the SSO, had some prioritization guidelines. And then priority C became the least aggressive category, really patients in whom a delay of 2 months or more would be unlikely to affect the outcome. And these patients were generally those with a depth of 0.8 to 1 millimeter or less than that. In concert with that, there were other guidelines from Ontario Health with respect to how we mixed surgery with systemic therapy. And I'm not going to go over this in a great amount of detail, but Ontario Health really tried to integrate everyone together to try to keep patients safe no matter what their needs were. So finally, some thoughts as we ramp up cautiously with respect to surgical melanomas. The bottom line is really every institution is quite individual and is quite different. And so we all have a backlog of surgical cases that we're trying to get through. And as a team, we're trying to prioritize who is more important than the next. We're still trying to use some mitigating strategies, neoadjuvant therapies, resection of disease in the clinic where we can, and use of some other anesthetic strategies like local dressings or regional blocks to try to get through some of the backlog that we have. But it's a challenge trying to triage in a fair and just way who deserves treatment ahead of the next, because really every patient is important. And we're working with our OR team constantly to try to evolve needs for things like preoperative COVID testing and how we keep, our workers, our nurses, our anesthesiologists, the day-to-day cleaners in the OR, all the team safe while we try to cautiously ramp up care. So I'll leave it at that for now, just for the surgical part, and I'll be happy to take questions later.
Thank you very much.
Back over to you, Kathy.
Oh,
yeah.
Sorry. I always like to talk into the mute button. Thank you, Dr. Dukong. We're going to shift gears a little bit now from surgery to medical oncology. And I'd like to thank you, Massey, for helping us at Save Your Skin to understand really what's been happening with immunotherapy treatment at the William Osler Health System in Brampton. So I'm going to, without further ado, I'm going to pass it over to you, Massey.
Thank you so much. So can you see my slide?
Yes, we can.
Hello?
Yes, looks great.
Okay,
Yep,
great.
that's
Thank
great. Thank you.
Thank you very much for the kind introduction and thank you for having me. So, yeah, this is indeed a challenging time with the COVID-19 pandemic, but I'm sure, again, we're all in this together and we can go through that together. So, in this presentation, I'm not going to talk about all the treatments for melanoma immunotherapy because it's nothing new to anyone. We all know what are those treatments. Just overall, because it's mainly concentrated on COVID-19, just want to do a general overview of immunotherapy. And what is the current knowledge that we have right now on immune-related adverse events is that we know that there are symptoms, both in mechanism and managing the toxicity from adverse events that commonly associated with the drug toxicity profile also of CTLA-4 inhibitors are greater than PD-1 inhibitors, and in combination, of course, also we all know that the higher rate of IRAE will be when we have combining them together, comparing to when we have only monotherapy approach. Any data that we have for managing IRAEs are based on retrospective reviews or clinical trials. No prospective trials have been conducted to date, but I'm so pleased to tell you that at Osler we have completed our clinical trials on a prospective trial on managing toxicity and so many other variables in terms of toxicity, which was presented recently at ASCO. So there are several IRAEs, which I use IRAEs so we can save time instead of saying related adverse events. They exhibit a characteristic pattern in the timing of their occurrence. We know that for both anti-CTLA-4 and anti-PD-1 therapy, skin and gastrointestinal toxicity tend to occur the earliest, while liver and endocrine toxicity tend to occur later. Rarely, IRAEs occur before the first 4 weeks of therapy. However, it may happen too, but majority of them is later. But for IRAEs, we should consider those toxicities throughout the therapy, as they can be developed at any time during the patient's clinical course, and we know that even after the treatment for patient, these face all these toxicities. So most of you, if you have any nurses on the line, are all very familiar with all these 5 pillars of immunotherapy toxicity management, and I'll quickly go over them to save the time also for the next session. So number 1 would be the prevention. So nurses should definitely understand the spectrum of immune toxicity and evaluate patients for any autoimmune, such as autoimmune disorder, prior organ transplantation, and the risk of graft loss also. Inactivation and split vaccines are permissible during immunotherapy, but live vaccines are not recommended. So they will also provide medication reconciliation, or even in some centers with BCMA, there's possible medication is being done by the nurses, including over-the-counter herbal supplements, immunosuppressants, and immune stimulants. The second pillar will be anticipation and how the immune system works. So what would be the potential signs and symptoms of that? Expectation of treatment and the proper nursing assessment, and read all the lab both at the baseline, pre-treatment, and in each visit. So we reading all of that, we can anticipate what we need. And the text has 2 sections in nursing and the patient. Nursing role in the section is monitoring regularly the patient and assess and monitor genetic toxicity, and home triage, which is extremely common to rule out any other causes, and use toxicity management guidelines, whatever each center is using based on national or international guidelines, and also determine if there is any need for hospitalization versus treating the patient in outpatient phase. The technique for the patient also requires close communication. Patients should understand to report any signs and symptoms as discussed, and if they go to any other health professional, their family doctor, or they have their own or mutual conversation with them, or admitted with another hospital, they have to keep us very informed. The treatment also is always based on available guidelines. And these cancer centers using different guidelines, basically Cancer Care Ontario or BC Cancer Agency, CC, ASCO, NCCN, these are all the common ones that are in practice and different cancer centers use them to manage toxicity.
Massey,
yes.
Excuse. Sorry to interrupt, Massey. Your audio is just a little bit cutting in and out for us. I know we were clear earlier. I wonder if are you on speaker by chance, or? So sorry to interrupt.
Is it better now?
Yes, that sounds good. Yes.
Yeah, that's good.
Okay. Okay.
Sorry about that.
Okay,
Thanks.
sorry. You should have just texted me a message and I couldn't do that. Sorry. Okay, so I will just, for one or two slides, I just want to switch to the lung cancer, because this is important to know that the combination of immune checkpoint inhibitor therapy, they can bring unique and very new challenges secondary to overlapping of adverse event profile. The Hofner group, they reviewed the ICI therapy with platinum-based chemotherapy in lung cancer patients, and interestingly, they revealed no new safety signal. So no evidence of unexpected or unanticipated toxicity with the combo treatment, which was very interesting to see. So they also found that there were 5 systems that are on highest risk of overlapping toxicity, and knowing the adverse event profile and the timing of these AEs for each agent is very important, because from chemotherapy adverse events, they occur within 1 or 2 weeks, and IRAEs may occur days, weeks, months, and even after discontinuation of immunotherapy. So it's really critical to understand the toxicity profile and differential diagnosis. It's also important to mention that I was reading and looking at the Oncology Times and an interview of Dr. Jeff Weber, who is another expert in US in melanoma. So the first published reports of the COVID-19 related pneumonitis demonstrated radiologic findings that are quite similar to ICI-associated pneumonitis. That was very interesting. So it's a well-known connection that we all know that has been documented in the literature and is based on the clinical presentation and the likelihood, of course, of cytokine release syndrome, CRS, that can occur with checkpoint inhibition, but it is also more common with COVID-19 infection. So that is good to keep in mind for our patients. So there are challenges, of course. We know that chemotherapy's adverse events are predictable and related to the treatment time, versus immunotherapy is unpredictable and it can occur anytime. So phone triage and telemedicine are the common practice that majority of us, I can say, are following. So once we will determine that the optimal treatment approach for our melanoma patients has been established, so of course the next hurdle at this time of COVID-19 is monitoring our patients for IRAEs, which is very critical, especially when in IO combo. So most of the cancer centers have different guidelines and approaches to this, and we have been transitioning to phone triages and telemedicine appointments, and I'm sure most of the other cancer centers have done that too. And we have converted approximately 75% of the practice to virtual. Some centers are asking even patients to go to the local lab instead of coming to the hospital to have blood drawn for response assessment. or toxicity management. For our sickest patients or elderly, we do have a huge elderly population, specifically like my melanoma patients, majority of them are 75 and above. So those who do not, we don't want them to take the risk even to go to the local lab. There should be a possibility to arrange the blood drawn at home for those patients. And many of us now have the experience with the administration of immune modulatory agents. So this is why the cancer immunotherapy community is poised to contribute to the current fight against COVID-19. And I'm honestly very proud to be part of that too. So when Cancer Care Ontario and CANO, which is Canadian Nursing Association, we do have a phone triage guideline, and part of that is to understand our past history of our patients. We all know that some of the patients may not be reliable. Even when we see them, they will not pass the right information to you, or they will give different information or messages to the physician, to the pharmacist, to the nurses. So knowing if the patient that you're going to talk to is reliable and accurate, and are they really following the phone instruction? We know our patients so well, unless they are brand new to us, and it is a bit challenging, but we have to understand really in this comprehension, what is the sense of urgency? Is there any language barrier, which is huge, very, very huge at Osler. So that is why we started also translating whatever we have created in our IO clinic, because of that diversity at Brampton. And knowing the patients, where do they live, is there any available transportation for them, and also what are the resources that they are using, and any guidelines that we want to make sure they have it handy. So cannot emphasize education. So during this time, we have heard of the unique ways that all the nurses are meeting the patient's need and providing the quality care with limited resources and in this uncertain time. It is very important to educate our patients of all the signs and symptoms, because they may not even go back to see their oncologist for the treatment of those immune-related adverse events. So it's important to make sure they are clear to be able to identify themselves. And telemedicine also is another different way that people are not coming to see us anymore physically. We cannot do an in-person physical exam, and clinician needs to find ways of assembling missing information. So we have to become more smart when we are doing telemedicine and assessing our patients. For example, I may ask my patients, could you please check your blood pressure, or if they have any problem with their weight, with their skin. So can you show me the rash that you're talking about, and watch that, over time, and then see if there is any changes in the grade. So these are things that we are doing, but even the abnormalities in the rash or lower extremity edema, these are the assessment we are doing virtually. But honestly, as good as telemedicine is, I think it covers approximately 70% of the information, at least I can obtain in an in-person visit. I love in-person visits. I just want that human connection with my patients. And the clinicians may miss critical information, such as how the patients walk in the room, or how is it, especially our elderly, or are they even able to get to the exam table? So therefore, I don't think that telemedicine is really the best way to treat the patients, especially cancer patients, but it is the best way to treat our patients now during this pandemic. So we will take it, and we really cherish the time. So lesson learned on ground oncology patients. So the first group that have published detailed oncology patient care guidelines was the Seattle group in Washington, and they focus on making treatment determinations such as use of less immunosuppressive regimen and considering ICI monotherapy over combination, and in effort to decrease toxicity during crisis and any potential need for steroids. So these are things that is in their guidelines that they have published that. And in terms of infection control, which is the backbone of our practice at Osler, we pre-screen, pre-visit phone calls, and visitor limitation. Of course, it is in all the cancer centers, I believe, all the hospitals, I have to say, and triage isolation patients that are suspected of COVID-19. And at this time in our institution, we are masking all staff as well as patients, regardless of their symptoms. And due to the higher risk of infection, when traveling to the hospital, the right treatment decision and timing is very critical. When considering the IO treatment for our melanoma patients, patients who do not have COVID-19, we should balance the risk and benefits for individuals based on their specific situation. For example, a BRAF negative patient that is newly diagnosed, and of course BRAF is negative and is, has a diagnosis of high risk anal mucosal melanoma, which is one of our patients who initially presented with severe pain and bleeding. The risk of rapid progression may outweigh the risk of coming into the clinic for treatment. And IO combo-based therapy should be recommended for this patient. And in selected cases, when we need more intense care and supervision and observation, and patients that need more visit to the outpatient clinic, for example, for pain management or radiation therapy. Then some centers, I know that they prefer admission to their COVID-19 free floors in the hospital to avoid frequent travel. That makes more sense to me, as it is safer to keep a patient in the hospital for 3 to 5 days for treatment than to have a patient traveling several times back and forth to the hospital, have multiple interactions, and so on. This slide, just again, some of these challenges. So maximizing telemedicine to minimize patient travel and to come to the cancer centers. So in inpatient, of course, no visitors policy is in place, and knowing telemedicine and practicing online is going to be very common now. And in using separate COVID screening center, if possible, is the best. It's not, it's a bit challenging for every center, but it's the best practice, and especially urgent care areas for only oncology patients. Technology, I have to say, it is maximized now, especially in during COVID and in ICU. We have to make sure, in terms of infection control, if it is possible, the IV pumps stand outside the rooms, and use of iPads for communication, which is very common these days. And I know that some of the centers also are re-sterilizing their N95 masks. So having proactive discussions about the goal and of care, and especially palliative care, are so vital during this very challenging time. And we have to keep in mind that another point is financial toxicity. Financial toxicity has been, if it has been an issue pre-COVID, it only escalates with job and insurance losses now. And this is something that we definitely have to keep in mind and get our social worker and other staff that are involved in the care of our patients to see how we can help them. And we have to monitor them. Not only the patients, also healthcare workers needs to be monitored closely in terms of signs and symptoms of COVID-19. They are doing an amazing job in frontline to keep our patients safe while taking care of themselves and their own families. So spiritual and emotional well-being of the team is also need to be proactively met. And at Osler, our spiritual team and well-being group are actively providing support to our healthcare team. I could not stop this presentation without not talking about our eye clinic in Canada. So it has been an immense pleasure for me to work with Dr. Parneet Chima, who is the clinical lead for the first immunotherapy clinic in Canada. And we started 2 years ago. And by now I can say that we have established a very good guidelines and setup, and the clinic is running smoothly considering COVID-19 pandemic. We are very proud of what we are doing in this clinic. And the goal of the clinic when we started was to be able to generate standardized, reproducible information, and to be able to implement immunotherapy with all those standardization across our patient population in different cancer centers. And this is what has happened. And some of the resources that I think they are useful for you, I'm going to show you here, is the Cancer Care Ontario. You can see the first one. The AIM Melanoma is that Kathy at Save the Skin Foundation, myself and the group of team in Canada worked with AIM, which is part of CIPS US, and we do have our Canadian resources in the website. So this is the link that you can view them, and we are also very proud that we worked together to create them. Last but not least is the guide to implementing cancer immunotherapy at your center. I just was able to put the table of content that is in this package that we are sharing with all the cancer centers, not only across our nation, but also CIPSI has actually signed a contract with us. They were very pleased and impressed with what we have created. And some of the information that are in this package, I just named them in this table of content. For example, you will see the diary, the sheets are all PDF fillable, and you can use or modify that based on what is usable at your center, based on your guideline or rules of the institution. And I have put on a website, which I wrote, it's coming soon, because I'm right now that I'm talking to you, this week I'm working on that website to go live, and we are hoping that the website will go live by mid next week. So you can just go to the website, get any information that you want, whatever is useful for you specifically at this COVID-19 pandemic time. The nurses can print that, have it handy, call the patients and fill it right there, and then they can just transfer that to the patient's chart. So this is something that is really useful, especially at this time that we are having a very common practice in phone triage and telemedicine. So I think we're not going to have any question right now, and I will hand over that back to you, Kathy. Thank you.
Thank you so much, Massey, for your presentation, and also a thank you for all the work that you've been doing on these useful resources. We get a lot of uptake from our patients at Save Your Skin. So thank you again for all of your work there with us.
Now thank you for your collaboration, Kathy. We thought it was not possible.
Thanks, Mass. Now I'd like to introduce you to Dr. Marcus Butler, a medical oncologist at the Princess Margaret Cancer Center, to tell us about the common side effects of targeted treatment in melanoma, how these side effects may overlap with COVID-19 symptoms, what to watch for, and how to effectively manage key common side effects of targeted therapy, especially during this pandemic. Dr. Butler, take it away.
Okay, so hi guys. So next slide. I have some disclosures. Next slide. So just to review why targeted therapy is important. This is data that was released last year at ASCO about 5 years of targeted therapy and its impact. Next slide. Basically, this was a study that looked at two big studies where dabrafenib and trametinib, that's a BRAF inhibitor and a MEK inhibitor, were combined and compared to controls, and then they put the all of this data together to look at the outcomes. Next slide. So we found that at 5 years, about a third of patients that had stage 4 disease and in the past would have very poor outcomes, were still alive and doing well at 5 years. Next slide. And if you if you look at that, so this is a slide that shows the data for patients who have normal LDH and less than 3 organs. Next slide. And then the final, so stay here for a second. So in terms of progression-free survival, a third of patients have no evidence of progression when you have very limited amount of disease, and a majority of patients are alive at that time point. And that's very similar to the data that we see in patients who are on single agent immunotherapy. Next slide. In terms of the impact of the patients who have targeted therapy, most patients unfortunately have progression when they're treated in the metastatic setting. However, if we look at patients who have no disease present and receive adjuvant therapy, that's where you've had your surgery and then we give a treatment to prevent recurrence. There is data that targeted therapy can have a meaningful impact. That data was analyzed and updated for the 5-year analysis this year at ASCO. Next slide. So this was a big study that looked at targeted therapy versus just monitoring with placebo and looked at outcomes. Next slide. We found that there were much fewer relapses. The green curve is much better than patients who received placebo in terms of relapse, so that the majority of patients have not had evidence of relapse compared to about a third of patients in the placebo group. Next slide. This was observed in all 3 subset stages. Stage 3A, next slide shows 3B, and stage 3C showed this significant difference. So even in the patients who had the worst potential risk for recurrence, had a significant benefit from taking the treatment and had fewer relapses. Next slide. Something that's called distant metastasis-free survival is a surrogate for overall survival, because we presumably distant metastasis is what patients will pass away from. That also was different between the placebo and the combination group. Next slide. And then there was, not this year, it was not updated, but in at the original release in 2017, there was a difference observed in survival that was seen, as you can see here. So that means that it appears that patients who receive targeted therapy in the adjuvant setting, there may be some patients who are cured of their disease and don't need further treatment given. Next slide. Now, the side effects of targeted therapy, especially for the most common combination that we use, dabrafenib and trametinib, are wide-ranging. They include pyrexia, that's fevers, fatigue, nausea. Sometimes patients will have headache, chills, diarrhea can occur, joint discomfort, rash, cough, muscle aches, and flu-like illnesses. Next slide. So many of these side effects that can be observed in patients either receiving treatment after the surgery has been completed or in the metastatic setting will overlap with symptoms of COVID-19. Next slide. Pyrexia is really common. So maybe 40% of patients don't have pyrexia, but a third of patients will have at least fever at what we call grade 1. Another third will have more significant pyrexia or grade 2 or even grade 3. Next slide. And many patients will have more than one occurrence. So you can see here the deep red color. A third of patients have multiple occurrences of these fevers. Next slide. So what is the strategy we've been using at Princess Margaret? And I will say that one of the advantages of an oral therapy is that you don't necessarily need to be trafficking to the hospital for an infusion. So you can receive your treatment at home, and we only need to intervene in person in the hospital by when you need to come into the clinic. So what we have been doing for patients is we do a COVID-19 swab before they begin therapy. We have a requirement to do a swab before patients are admitted to the hospital, as well as before they initiate treatment in the chemo suite. But even for our patients who are receiving oral therapies, especially targeted therapy, we perform a swab that should be negative for within 2 weeks of treatment. And then we try to administer the therapy and maintain social distancing. So we are alternating our virtual and inpatient visits for the initial therapy initiation. But that doesn't mean that we're not monitoring patients closely. We are having a laboratory assessment performed regardless of whether or not the patient is coming into the hospital. So we'll use a local laboratory if needed. So we are checking labs once a month, but alternating in terms of our visits. So we may see the patient, and then the next time we see them, we'll do it virtually, and then plan on having them come into clinic the following visit. If patients are very stable, we may be able to go 2 or 3 visits on a monthly basis without seeing them in person, but use the virtual visits. So in terms of the pyrexia, we're using the hold and restart algorithms, and I'll go through those in a few minutes. And there are a few elements that are important to point out. We are closely reviewing patients by phone or telehealth with video. I prefer the video compared to the telephone, but not everyone has adequate internet access for that. If a patient does experience pyrexia, we don't automatically assume that it's due to the drugs, but also review to make sure no one else at home is sick, and if necessary, we'll repeat the COVID-19 swab if patients are not getting better. Next slide. So this is a pyrexia algorithm that's becoming more popular in Canada. It's based on some work that was performed in Australia. So there is some data that suggests that for targeted therapy, dose reductions can result in inferior outcomes, and that a start and stop approach has some theoretical benefits in terms of having an anti-cancer effect, and there hasn't been any data to suggest that holding drug and then restarting has inferior outcomes. So this is a regimen we've been following. There hasn't been a perfect randomized trial to show this, but it looks like it works just as well. So patients on day 1, should they have fever, are told to stop taking their drug, and if necessary, we'll take an antipyretic like Tylenol or ibuprofen. Once the patient is symptom-free and off of antipyretics for 24 hours, they're able to restart treatment. Otherwise, we continue to monitor. And if the symptoms are continuing and not resolving, that's when we would consider a repeat COVID-19 swab and assessment, as well as laboratory assessment. Next slide. The intermittent strategy is been effective and studied in a few trials looking at adjuvant therapy, and seems to be an effective way of managing the pyrexia. However, there are some patients that just keep on having fevers, and those patients, the algorithm preceding COVID recommended prednisone as a way to control disease. And you may have heard on the news recently that another type of steroid called dexamethasone has been effective in treating patients with COVID-19. Well, that's reassuring, because if we give prednisone, there is a fear that it does impact the ability of the immune system to fight infections. But prednisone also blunts steroids blunt some of the overactive immune response that results in patients needing ICU care for COVID-19. So right now we're using prednisone. However, may want to repeat a COVID-19 swab before going down this path because of fear of immune suppression, but there is some early data to suggest that steroids can be used in patients with infection. The other alternative is to look at BRAF/MEK inhibitor alternatives as opposed to dabrafenib and trametinib. That's not an option in the adjuvant setting, because it's only received approval. Dabrafenib and trametinib have only received approval in that setting. But for stage 4, there's another targeted therapy option. Next slide. So the targeted therapy treatments that, in addition to dabrafenib and trametinib, that can be tried are vemurafenib and cobimetinib. That's approved in Canada, and we'll use this combination for patients. There's more skin toxicity, and that's the main reason that we don't go with vemurafenib and cobimetinib first. And then there's another combination. It's called encorafenib and binimetinib. That is a treatment strategy or treatment combination that's currently not approved in Canada, but there is indication that these drugs are going to be available hopefully soon, and the company is open to applications where you provide a rationale for why you would like to switch to encorafenib and binimetinib, and we can apply to Health Canada to allow us to import these drugs for patients. Now, so the advantages of targeted therapy, there are no IV treatments. We can use virtual management for these folks, but you know, in an appropriate setting. And then certainly a disadvantage is the pyrexia and other side effects that need to be managed. So I think we now have some time for questions for the three of us.
Thank you so much, Dr. Butler. I'd also like just to let the listeners know that Save Your Skin, in partnership with 14 other patient advocacy groups across Canada, right in the beginnings of the COVID-19 pandemic, put together an oncology resource hub. And it has 3 separate programs, one mental health and wellness section, One was a resource section nationally, and the third was a practical support section, which included things like getting patients to and from their treatments, getting their groceries delivered, really even getting technology to those patients that didn't have it. So we were trying to fill what we felt across the country with patient advocacy groups, a gap that we wanted to make sure it was covered throughout the pandemic. So if you would like access to that COVID-19 Oncology Resource Hub, you can let us know later as well. So again, thank you, Dr. Butler, as always. We do have a few minutes for questions. I see one up now. I will start that. Could you tell us how what we've learned from the COVID-19 pandemic that might be moved forward in cancer care? So something like telemedicine or rapid testing, anything that we've learned from the pandemic that we might help improve cancer care moving forward. And Dr. Butler, I'll start with you.
Well, I think that you kind of said it, that telemedicine has been rapidly adopted into our treatment strategies for patients. It's like too much time is often spent patients sitting around in crowded waiting rooms to be seen. I think there's a lot being learned as to how to deliver virtual medicine more efficiently and effectively. There, as Massey was pointing out, there's a lot of potential for missing things. So that, however, by having building in the ability to talk to patients virtually, review things, I think will be very important and won't go away when a vaccine is developed. And then we can actually, perhaps there will be examples where a patient comes in on a day they're having a scan. Well, they'll see their doctor for a physical exam, but they won't know the results of the scan. There may have to be another visit later on where, but that could be virtual, where the scan results are reviewed. That saves the patient having to come into the, travel to the clinic by half, because typically our routine is to have the scan and then go home and then come back to review the results of the scan. I think it is, as Massey pointed out, we really do begin to appreciate the times that we actually see our patients and can do a physical exam and treat that as a privilege and honor to be able to examine the patients and not take it for granted, because patients often travel a long distance to see us, and then we just sort of have a very quick exam or quick review. If we can sort of focus on that part more effectively, I think it's better patient care.
Fantastic. I got one more question. Actually, we're almost out of time. Dr. Lukong, you talked about backlog. So if this is for any of you, how will delays in access to diagnosis and surgeries be addressed? And Dr. Butler, this is probably more for you, is do we expect to see an increase in later stage melanoma patients in the future because of these delays? So, we know in melanoma, a diagnosis, a timely diagnosis is very important for our prognosis. So, how do you see the delays now within the surgery and the diagnosis being addressed moving forward?
I'll let Nicole, I think she was going to answer that first question, right?
Sure.
Yes,
so I'll address a bit of the backlog question. And I think each institution is managing this a little bit differently. At our institution, from the surgical side, in terms of managing the backlog, we've been working with our OR administration looking at the cancer cases within our hospital, and as a group trying to triage how do we figure out which patients get triaged first. And this is not only melanoma, but liver cancer and pancreas cancer and colon cancer and all sorts of things as well. So it's definitely a group effort, and it's a conversation that happens on a weekly basis to try to adjust to how we're managing. We've been, on the cancer side, given a little bit of extra operating time to try to get through extra cases as the virus is permitting us to do so now. But really, things are changing rapidly. I think from a diagnostic point of view for the clinic, we're not screening as much as we used to because we're having fewer inpatient visits. And in a disease that is much skin-based, seeing is believing. So there will definitely be, I think, a bit of a surge once we start to screen people a little bit more carefully through our clinics and through our dermatology clinics. And we'll have to integrate those patients in the months to come as well.
Yeah, so I think that's the big fear, is that we're, from a medical oncology point of view, our concern is all of the disease that's not being diagnosed. There are some tumors which are slow growing, and a couple of months may not make a huge difference. There certainly will be an impact in some cases, we won't know the level of impact until we look at the epidemiology of this a year, 2 years, 3 years from now. But I am pretty certain that as the surgeons are operating and are being able to perform their lymph node biopsies, that we're going to be identifying patients who need further therapy later this summer and into the fall. And when family doctors and dermatologists open up their clinics and diseases being diagnosed, that's going to impact us. And there'll be a kind of, instead of, basically it's been a steady stream in the past, but all of a sudden there's going to be a peak in patients who need management. And I think we're currently trying to figure out how we can meet that increased need and also maintain social distancing. And that will require that we utilize virtual care. We may have to extend our clinic hours so that patients are not all coming at the same time. I mix my virtual and in-person care so that I'm not, I don't want to be in a scenario where I'm twiddling my thumbs because I'm waiting for a patient to show up in 30 minutes. But we haven't quite figured out the balance yet, and we're working on trying to figure that out.
Fantastic. Massey, did you have anything to add?
No, I just want to echo Dr. Butler about having the patients in clinic. I still think it makes a huge difference, and that is a win-win situation, I believe. Like for oral treatment, it is much easier comparing to having the patients coming to the infusion center. But the thing is, I actually prefer if I have a brand new patient starting on immunotherapy to have the patients in the clinic. If I want, or the patient needs to come in to break a bad news, I really don't like to, do that virtually. There are certain appointments that I think it's much better to have the patients physically there, and collaboration with all the other teams. Actually, I had a patient last week going to Princess Margaret, and the whole team arranged when the patient goes there, the surgeon, medical oncologist, radiation oncologist, and the dietitian. It was a very long visit, but with one visit, they arrange everything for the patient to see the patients and minimize their visit. So these are things that I think for now all the cancer team in anywhere they're practicing have to consider to do that, to make sure the patients will not wait for, especially those looking at the CT scan at the same time, or even talk to the radiologist to have their opinion. We can do this. This is a very critical time, and we have to help our patients for that.
Amen to that. Thank you very much. I'm going to pass it back over to you now.
Wonderful, thank you. Thank you very much, Dr. Lokong and Massey and Dr. Butler, for sharing your insights with us. We appreciate your time today and in preparation for this session very much. Thank you. And thanks everyone for attending today's webinar. Again, I'll mention that this session is recorded and it will be available for viewing on the Save Your Skin website and YouTube channel as of tomorrow. We'll also include the links that Massey and Kathy mentioned as well, so that you can look at those additional resources if you'd like to see them. If you have any other questions and the questions that we missed, we will get back to you by email. Please feel free to send them to myself, Natalie@saveyourskin.ca. Or to Kathy, Kathy, @saveyourskin.ca. Thanks again to our presenters, and thank you to everyone for watching. This ends the webinar session. Okay, thank you. Have a good evening.
Thank you. Bye-bye.
Thanks. Bye-bye.
Thanks, everyone.